Hello, good morning. My name is Dr. Fayaz, resident of urology, and today I'm going to present the one of the most crucial topic in urology, as it is a time-sensitive urological emergency, a significant impact on erectile function. And I'll thank Dr. Mubin for being the moderator of the session. So the content of our presentation would be, we'll explain what's priapism, the anatomy and physiology of erection, the pathophysiology of priapism and its epidemiology, and its types and etiology, and how to evaluate it and diagnose it, and finally the management. So what's priapism? Basically, the definition of priapism is that it's a full or partial erection that continues for 4 hours beyond sexual beyond sexual stimulation or orgasm, and or is unrelated to sexual stimulation. So any any erection that lasts for more than 4 hours can be classified as priapism. So this picture is actually the word priapism comes from the Greek god Priapus, who was known to be the god of fertility. So the word comes from there. So to understand priapism, we have to understand the anatomy and physiology of the erection. So what actually happens that, as we know that the penis has two erectile tissues that is known as corpora cavernosa and corpus spongiosum. So there are two corpora cavernosa, which after getting there is a nitrous oxide in the blood that's released, and then these erectile tissues, the smooth muscles in these erectile tissues get relaxed, and the blood gets into these tissues and through the cavernous artery, and they swell up. So basically, when they swell up, they cause the vasoconstriction, or they cause the constriction of the venules around them. So the blood gets trapped into the corpora cavernosa and does not let to go out. So this causes a relaxation, and when the stimulus is over, these smooth muscles contract and the blood gets out through the venules. Major neurotransmitter is nitrous oxide.
Penile anatomy is very typical, but in priapism, we limit ourselves to corpora cavernosa and corpus spongiosum. उसकी वजह ये है कि these are the main parts जिसमें abnormality होती है. Now we have two corpora cavernosa and one corpus spongiosum. लेकिन अगर आपने गौर किया हो तो फयाज ने जो बात बताई है वो सिर्फ ये बताई कि corpora cavernosa में ब्लड फिलअप होने की वजह से ये प्राइपिज्म में ये abnormality होती है. But it doesn't occur in corpus spongiosum. किसी को पता है क्यों? कभी किसी ने सोचा कि क्यों? हालांकि स्पंजियोजम भी है, उसमें भी वेनस चैनल्स हैं. कॉर्पोरा कैवर्नोसा में क्यों डायलेटेशन होती है, क्यों ब्लड फिलअप होता है? द सोल रीजन इज ट्यूनिका एल्बुजिनिया. कॉर्पोरा कैवर्नोसा पे जो एल्बुजिनिया जो उसको कवर अप करती है, दैट इज वेरी रिजिड, ठीक है. और कॉर्पस स्पंजियोजम को जो करती है, दैट इज वेरी इलास्टिक. उसका रीजन ये है कि अगर कॉर्पस स्पंजियोजम को पता है, कॉर्पस स्पंजियोजम इज सराउंडिंग द यूरेथ्रा. अगर उस पे अगर रिजिड ट्यूनिका एल्बुजिनिया हो तो इरेक्शन के दौरान इजैकुलेशन भी ना हो पाए, ठीक है, क्योंकि वो भी ब्लॉक हो जाएगा यूरेथ्रा. तो यूरेथ्रा को ओपन रखने के लिए नेचर ने हमें ये चीज दी है कि वहां की जो ट्यूनिका एल्बुजिनिया वो रिलैक्स होती है. और जो रिजिड होती है, जब ब्लड फिल्स अप इन द कॉर्पस कैवर्नोसम, तो जब वो डायलेट होते हैं तो जो ट्यूनिका एल्बुजिना जो बिल्कुल रिजिड हो जाती है, उसकी वजह से एक तो इरेक्शन मिलती है, दूसरी बात है कि वेनस जो चैनल्स होते हैं ना वो ब्लॉक हो जाते हैं, जिसकी वजह से आउटफ्लो रुक जाता है, ठीक है. दैट इज द बेसिक मैकेनिज्म ऑफ इरेक्शन, ठीक है.
Okay, so what happens in priapism, the pathophysiology of priapism is that, as we know that blood comes through the arteries and goes out through the veins. So any obstruction in arterial inflow or venous outflow can cause priapism. So if the blood comes in through the arteries but cannot get out from the veins, it will be trapped in the corpora cavernosa and will cause a prolonged erection. So priapism typically involves the engorgement of corpora cavernosa, as Dr. Mubin explained it, and the spongiosum is spared. It is not it is not filled with the blood. The epidemiology and morbidity of priapism. Basically, the causes vary by population. The sickle cell disease is a major cause in children and some adult populations. And the use of erectogenic agents like medications injected or used for erectile dysfunction also account for priapism in adults. And by risk by age and race, more common in certain groups, like in 5 to 10 years of the children, in children of 5 to 10 years, and adults from 20 to 50 years. Among those with sickle cell disease, there is much higher incidence. And the key complication, the morbidity of priapism is erectile dysfunction due to corporal fibrosis. So as we will discuss later that how does the priapism cause erectile fibrosis and then eventually erectile dysfunction. For example, if the ischemic episode lasts less than 24 hours, chances of recovery of function are much higher. Beyond that, the erectile dysfunction becomes more likely. The types of priapism. So basically, before discussing the types, we'll see what's the cause or what are the most common causes of priapism. So as you discussed that sickle cell disease, the hematologic causes are the most common causes, in which the sickle cell disease is the most common. And we'll discuss later how it causes the priapism. And then there is thalassemia and leukemia. In leukemia, basically there is an increased count of WBCs, which again causes makes the blood more viscous and gets that's why the blood gets trapped into the corpora cavernosa. Malignancies can also cause priapism, and basically the genitourinary malignancies in which there is a CA prostate or a CA bladder, which can get metastasized into the corpora cavernosa and cause nodules into them, and basically disrupts the anatomy of the corpora cavernosa, and due to which the blood gets trapped into it. And then there are also some infectious causes like scorpion sting and malaria, and it basically has to do something with the nerves, and it causes the increased neurostimulation, which can cause prolonged erection. Trauma is also one of the reasons of priapism. In trauma, what happens is basically that it causes the non-ischemic, which we'll see later what's the non-ischemic type, and it causes the fistulous formation between the artery and the corpora cavernosa, which causes the high flow priapism. Then there are also metabolic disorders like amyloidosis, Fabry disease, and gout. Neurologic disorders like spinal cord compression, multiple sclerosis, and spinal cord injury can also cause priapism. And then there are medications like antipsychotics, antidepressants, and anticoagulants, which can also cause priapism. There are also some drugs like alcohol and cocaine, which can also be linked to the cause of priapism. Alcohol, basically, the basic mechanism is still not known because it can also cause erectile dysfunction. But there are a few studies which explain that it has also been a reason of priapism. And then there is cocaine and marijuana.
बेसिकली मैलिग्नेंसी में जैसे इन्होंने बताया कि मेटास्टैटिक अगर नोड्यूल्स पहुंच जाए वहाँ पे, व्हाट इज द अदर कॉज मैलिग्नेंसी में प्रायपिज्म का पता है? बेसिकली मैलिग्नेंसी इज अ थ्रोम्बोजेनिक स्टेट. ठीक है, अगर आप जितने भी यहाँ पे कॉजेज देखें, हेमाटोलॉजिक हो या इट्स मैलिग्नेंसी, इन्फेक्शंस, मेटाबॉलिक डिसऑर्डर्स लाइक एमिलोइडोसिस वगैरह में तो प्रोटीन डिपोजिशंस होना शुरू हो जाती हैं, जिसकी वजह से ब्लड फ्लो इफेक्ट होता है, क्योंकि वेनस चैनल्स हैं, दे गेट ब्लॉक इजीली. अगर मैलिग्नेंसी में वैसे ही बॉडी में थ्रोम्बोजेनिक स्टेट होती है, ल्यूकेमिया, थैलेसीमिया की बात करें तो डिसऑर्डर्स ऑफ द ब्लड सेल्स, ये सारी की सारी वो डिजीजेस हैं जिसमें इस्केमिक प्रायपिज्म के चांसेस बहुत ज्यादा बढ़ जाते हैं. ठीक है, बाकी the thing remain about spinal cord compression. किसी को पता है न्यूरोलॉजी में क्या ऐसा होता है कि स्पाइनल कॉर्ड कंप्रेशन हो जाए तो क्यों प्रायपिज्म हो जाएगा? मतलब हो नहीं जाएगा, हो सकता है, इट्स रेयर बट हो सकता है. पैरासिम्पैथेटिक ओवरफ्लो. ठीक है, पैरासिम्पैथेटिक ड्राइव. ठीक है, अगर किसी का स्पाइनल कॉर्ड इंजरी हुई है और उसका सिंपैथेटिक डिस्टर्ब हुआ है तो बॉडी विल गो इन अ पैरासिम्पैथेटिक ड्राइव और उसकी वजह से प्रायपिज्म हो सकता है. ठीक है.
So now let's understand the classification or the types of priapism. The first is ischemic or low flow priapism. So what happens is actually, as we talked about the circulation and the mechanism of erection. So basically in ischemic priapism, there is a failure of venous outflow. As we talked that when the corpora cavernosa swell up, they actually obstruct the veins, and then when it relaxes, then the blood gets out through the venous flow. But if there is any obstruction in the veins, then this blood gets trapped in, and it does not let the penis to detumescence. And the stasis leads to progressive hypoxia, hypercarbia, and acidosis. Basically, the blood that is trapped in that the oxygen saturation of that blood decreases, and then carbon dioxide increases, and the pH also falls. So this causes the blood to trap in, and then further causes other ischemic changes in the corpora cavernosa. So what happens to the tissue is in 4 to 6 hours, there is a rising pain due to ischemia, and then by 12 hours, there's endothelial injury, platelet aggregation, and interstitial edema. And then beyond 24 hours, there is a smooth muscle necrosis, fibrosis, and if no intervention is done beyond 24 hours, there is a high risk of permanent erectile dysfunction. So pathophysiology of Priapism in sickle cell disease. What happens in sickle cell disease is that the hemolysis releases free hemoglobin, which scavenges the nitric oxide, and reduces its availability. The sickle cell also releases arginase, which depletes left L-arginine and the substrate for nitric oxide synthesis. There is oxidative stress also that further lowers the nitric oxide bioavailability, and endothelial dysfunction and impaired smooth muscle relaxation. Hemolysis and then reduced nitric oxide causes priapism, increases blood viscosity and painful crisis. And it's also associated with hemoglobin, increased hemolytic markers like reticulocyte count, bilirubin, and LDH. And there are also other complications which happen in sickle cell disease, like pulmonary hypertension, leg ulcers, stroke, and Aspen syndrome, which is sickle cell disease plus priapism plus exchange transfusion and neurological events.
Basically, sickle cell disease is a hematological abnormality. But as a urologist, हमें पता होना चाहिए कि what is sickle cell disease. क्योंकि जब भी priapism की बात आती है ना, तो in children, priapism is very common among the patients who are already suffering from sickle cell disease. तो at least sickle cell disease की आपको ये पता हो कि sickle disease क्या होता है और why it is known as sickle cell. ठीक है. सबसे पहली बात, it's a hereditary disorder. ठीक है. मदर फादर दोनों से जो जीन्स आते हैं उसमें ये डिजीज पाई जाती है उन बच्चों में. दूसरी बात, जो आरबीसीज होते हैं, बेसिकली जो जीन म्यूटेट होती है, जो डीएनए म्यूटेट होता है, वो आरबीसीज के अंदर म्यूटेट होता है, जो कि फॉर्मेशन करवाता है हीमोग्लोबिन की. अब जब आप हीमोग्लोबिन का बेसिक स्ट्रक्चर देखें ना, तो देयर आर 2 चेन्स, अल्फा चेन, बीटा चेन्स. द डिफेक्ट ऑफ जीन विच कॉजेज दिस एब्नॉर्मैलिटी इज इन बीटा जीन्स. ठीक है. उससे प्रॉब्लम क्या होती है कि जब अल्फा और बीटा जीन्स जब नॉर्मल होती हैं तो शेप ऑफ द आरबीसी इज फ्लेक्सिबल. ठीक है. जब वो किसी भी नैरो वेन्यूल से या आर्टेरियोल से पास होता है ना, तो इट गेट्स प्रेस डाउन. ठीक है. बट जब ये बीटा जीन्स जो म्यूटेट होती हैं, तो उसके बाद द फ्लेक्सिबिलिटी, द आरबीसी लूजेस इट्स फ्लेक्सिबिलिटी. ठीक है. और उसका जो शेप होता है ना, अल्टीमेटली एज अ सिकल शेप हो जाता है. अब वो सिकल शेप जब भी किसी एक नैरो आर्टेरियोल या नैरो वेन्यूल से जाएगा, तो वहां पे वो स्टक करेगा, अल्टीमेटली लीडिंग, वही वाली बात, थ्रोम्बोसिस वाली बात, और अल्टीमेटली इट लीड्स टू प्रायपिज्म. उसके बाद ही सारी बातें आती है कि जब वो वहां पे टूटेगा, देन वो हेमोलाइसिस होगी, फिर फ्री एचबी, देन स्कैवेंज द नाइट्रस ऑक्साइड. और नाइट्रस ऑक्साइड के बाद जो तीसरा जो पॉइंट इसमें कि इम्पेयर्ड स्मूथ मसल रिलैक्सेशन, ये कहाँ का ये आर्टरीज का होता है. जब आर्टरीज का जो स्मूथ मसल होते हैं वो रिलैक्स नहीं हो पाएंगी. ठीक है.
Okay, so then there is another type of priapism that is known as non-ischemic or high flow priapism, and in this it's basically due to any trauma, and it can also be due to other reasons, like the treatment for ischemic priapism can also cause non-ischemic priapism, and then malignancies can also cause non-ischemic priapism. So what happens is basically that due to any trauma, there is a laceration of cavernosal artery, and then or there is also the formation of arteriosinusoidal fistula. So basically, as we discussed, that the blood, when the blood is trapped into the corpora cavernosa, so the inflow from the arteries stops because the blood is already there. So basically the flow stops. But if there is a fistula formation due to any trauma or malignancy or any other malformation, so the blood keeps coming into the cavernosa. So the flow is continuous. So we call it high flow priapism, because when we see on the Doppler ultrasound, we can see that the arterial flow is continuous. It does not stops. So this is called non-ischemic priapism, and the corpora are partially rigid because the venous occlusion is not there. The blood is coming out also, so there is not very rigid erection. And the oxygenation is also preserved because the arterial blood is also, the fresh blood is also coming in, and there is minimal ischemia, less pain than the ischemic priapism, and the erectile tissue damage is also very uncommon. Then there is stuttering priapism. This happens mostly in patients with sickle cell disease, that there is recurrent self-limiting ischemic episodes of priapism in those patients, and is often associated with sickle cell disease and other hematologic dyskaryosis, and it leads to cumulative tissue injury, and there is a risk of progressive erectile dysfunction. So because there are recurrent episodes, so any of these episodes can also convert into ischemic priapism, or any they can have one ischemic episode of one ischemic priapism and then others non-ischemic. So this is it's self-limiting, but it keeps on coming and going. So evaluation of priapism. First of all is the history. The history is the most important part in evaluating the priapism. So first of all, we have to know that how long the erection is persisted, because as we discussed earlier, that in the definition it is that more than, if the erection persists more than 4 hours, then we'll classify it as a priapism. And it's also important to know that if the patient has not taken any erectogenic agents, or if he's having any pain also. The pain is also an important factor, because through this we can differentiate between ischemic and non-ischemic priapism also. If the patient has had any past episodes which can give us clues about his hematologic disorders. For example, as we discussed that in sickle cell disease there are starting or recurrent episodes, or if a patient has any what's his baseline erectile function, and then there is also the use of drugs, as I told that there are some erectogenic agents which can also cause prolonged erection but not priapism. And there is any history of malignancy or any trauma, it is also important. So as we discussed that non-ischemic priapism, it is caused due to trauma, and any in trauma or any malignancy. So we have to also evaluate about the history of malignancy. Or is there any penile prosthesis present, or any other recent urological surgery, because we will also see that some urological surgeries can also cause priapism. After history, we have to the physical examination. We have to see the rigidity, because the low flow priapism causes rigid erections, but the normal corpus spongiosum therefore soft glands. So as we discussed in the definition and in the anatomy of in the erection, that the erection basically it is only the corpora cavernosa which is rigid, and the corpora spongiosum is not rigid. So we have to see this also, that if it is only the corpora cavernosa that is involved, then we can label it as a priapism. Tenderness and pain is also present, and we have to also look for any other lesions to give us any clue about the malignancy, or any other like if there is a trauma or any malignancy, we can look for nodules around the penis. And then there is we have to also look for the presence of prosthetic device, regional lymphadenopathy, and rectal tone. As we discussed, that spinal cord lesions can also cause priapism. So if there is the rectal tone is also absent, then it can also indicate towards the spinal cord lesions. In investigations, the baseline we have to see for the blood count, like we discussed that increased WBCs can also cause the priapism, and then there is sickle cell disease in which there are hemoglobinopathies, and then the coagulation profile, which can also indicate us towards the etiology of the priapism. Then the most important is the cavernosal blood gas analysis. So in ischemic priapism, the blood is dark, and the low oxygen and high carbon dioxide, hypoxia and hypercarbia, and low pH. And in non-ischemic, it's closer to arterial values. So as you can see that when we aspirate the blood, basically in emergency, we have to aspirate the blood through the corpora cavernosa. First it is also therapeutic and diagnostic. Diagnostic means that if the blood is very dark, and we send it for the blood gas analysis, and we find that the oxygen saturation is low, and the pH is low. As you can see, it's less than, our saturation is less than 30, and carbon dioxide is more than 60, and the pH is less than 7.2. So this will indicate that it's ischemic priapism. And in non-ischemic priapism, as I told you, that it's the arterial flow is continuous, so the saturation does not fall. It's more than 90, and it's equal to almost equal to the blood, and the pH is also 7.4. So this is very important, as aspirating the blood through the corpora cavernosa in priapism is very important, as it is also therapeutic, that we have to determine cause a detumescence, and also to diagnose what type of priapism it is. Then there is color Doppler ultrasound, which can also help us in diagnosing priapism. And it also distinguishes between low flow priapism and high flow priapism by measuring the arterial venous flow. So the image on the left, you can see that there is very little arterial flow. There is no sign of arterial flow in the corpora. And on the left side, on the right side, you can see that there is a continuous flow, which also represents the also represents the fistulous formation. MRI has a limited role. It has three possible roles. Imaging of well-established arteriosinusoidal fistula is if we diagnose it, if it is a non-ischemic priapism through the blood gas analysis and color Doppler, and we want to see if there is any arteriolar sinusoidal fistula present, then we can go for MRI and look for the site of the fistula. Or there's also the presence or if there is any thrombus present, if you want to know about the extent of tissue thrombus, corporal smooth muscle infarction, and it can also indicate towards corporal malignancy and metastasis. So let's come to the management now. So in ischemic priapism, our immediate goal is to relieve pain and stop erection, because as the word suggests, it's ischemic. So if we do not intervene as soon as possible, it will cause deleterious effects, and it will lead to fibrosis and then to permanent erectile dysfunction. So relieving pain is very important in ischemic priapism, and we have to stop the erection and restore the normal penile flaccidity and avoid long-term damage. So the first line management is aspiration of corporal blood. And sometimes this alone succeeds in resolving the condition. In 36 to 40% of the cases, the first line management and aspiration of the corporal blood is enough. And if aspiration is not enough, then also the injection of sympathetic agonist, alpha-adrenergic agonist like phenylephrine is also used, and it is applied intravenously at intervals, and which causes the detumescence to occur. If it is and if does not resolve and keeps on coming again, then there are other surgical options which are called surgical shunts, and that allow the venous drainage. There are various styles which we'll discuss in detail later. And in very prolonged cases, ischemia more than 36 hours, then of course we have no option to save the tissue, and then we have to look or think about the penile prosthesis to preserve the structure and prevent the fibrosis. So in aspiration, this is basically the anatomy, and so we can see that there is a neurovascular bundle at the top and the urethra at the down. So we have to do the aspiration in between. So we can go from we have to go from the 2 o'clock to 10 o'clock position, aspirate or inject the needle at 2 o'clock or 10 o'clock position. So it is a recommended initial treatment of ischemic priapism and should be repeated until the fresh blood is obtained. So we have to, what we do is basically we inject the cannula at 2 or 10 o'clock position in the corpora cavernosa, and keep on aspirating the blood. And through the visual inspection, we can also confirm that it's a dark blood. So we have to keep on aspiring it until we get a fresh red blood. So and it can also be sent for blood gas analysis, in which there is the signs of acidosis and low oxygen saturation. And we have to also keep on compressing the penile shaft to keep on secreting the blood. And basically a large needle is used, 19 gauge needle is used, aspirating the shaft until it is soft. The shaft is permitted to refill, and the compression is reapplied and aspiration repeated.
The question is कि कितने वक्त के लिए, अगर if you are standing near the bedside of the patient who is having a priapism, और आपने diagnose कर लिया कि it's ischemic priapism, and you plan for the aspiration, तो aspiration तो आपने शुरू कर दी, 2 और 10 o'clock पे आपने needle डाली और आप aspirate करना शुरू हो गए. Now कितने वक्त तक आप करते रहेंगे उसको? Any idea? Yes, exactly. 10 minutes. 10 to 15 minutes आप उसको करेंगे. अगर उसमें आपको fresh blood मिल जाता है तो then it's fine कि उसकी erection detumescence हो जाएगी. लेकिन अगर आपको नहीं मिलता तो then you have to move forward to the next step. ठीक है.
Okay, so this is you can see manually it's how the injection is applied and the blood is sucked through the corpora cavernosa. And then the last image represents the injection of phenylephrine. We will discuss how it is injected. So phenylephrine is an alpha-1 adrenergic agonist, and it's It has also some gonadotrophic cardiac effects. So phenylephrine is given at can be concentrated as 200 microgram per ml, and normal saline administered intermittently as a dose of 0.5 to 1 ml.
Basically, then you have to move towards the next step. Next step is alpha adrenergic injections. Basically, phenylephrine is alpha 1 adrenergic agonist. ठीक है, बेसिकली ये करता क्या है कि दिस कॉन्स्ट्रिक्ट्स द आर्टरीज. तो जब आर्टरीज कॉन्स्ट्रिक्ट हो जाती हैं तो वहां पे ब्लड फ्लो कम हो जाता है और इट गिव्स द वेनस चैनल्स अ रूम टू एम्प्टी द पेनाइल शाफ्ट. अब बात ये कि हाउ टू प्रिपेयर इट. ठीक है, एज अ यूरोलॉजिस्ट अगर प्रायपिज्म आ गया तो आपको पता होना चाहिए कि हमें इसको प्रिपेयर किस तरह करना है. ठीक है, तो अगर इसका आप वाइल देखें फिनाइलेफ्रीन का तो इट्स 1 ml वाइल. ठीक है, जिसमें 10 mg फिनाइलेफ्रीन होता है. ठीक है, आपने उसको 1 ml को डाइल्यूट करना है 19 ml ऑफ नॉर्मल सलाइन. ठीक है, तो इट विल कंप्लीट अ 20 ml. 20 ml अगर 10 ml में 20 ml में 10 mg ऑफ फिनाइलेफ्रीन हो गया. ठीक है, अगर आप उसको 10 से डिवाइड करें तो देयर विल बी 0.5 mg पर ml. ठीक है, तो 0.5 mg का मतलब ये है कि 500 माइक्रोग्राम्स आपने उसका भी हाफ देना है उसको. ठीक है, तो दैट कम्स आउट टू बी 0.25. तो आपका जो रेंज ऑफ डोज जो बनता है ना फिनाइलेफ्रीन के लिए वो बनता है 0.2 ml टू 0.4 ml. उसका रीजन ये कि 0.2 टू 0.4 0.2 ml को अगर हम कंसीडर करें तो इट्स 200 माइक्रोग्राम 100 माइक्रोग्राम जो आप देंगे, और अगर 0.4 पे अगर आप जाएं तो दैट इज ऑलमोस्ट 200 माइक्रोग्राम्स. 200 से अब कहते हैं कि आई वाज वाचिंग सम रॉयल कॉलेज वीडियोस, तो उसमें आप कहते हैं कि 250 भी आप दे सकते हैं, तो आप 250 माइक्रोग्राम भी आप दे सकते हैं. आपने करना कब तक है, बात यह है. अगर आप फिनाइलेफ्रीन देने जा रहे हैं, ठीक है, तो सबसे पहली बात तो आपके पेशेंट को मॉनिटर लगाना चाहिए. इवन इट्स अ सेलेक्टिव अल्फा 1 एड्रेनर्जिक एगोनिस्ट, लेकिन इसके साइड इफेक्ट्स होते हैं जैसे कि हेडेक, इर्रेगुलर कार्डियक रिदम्स, हाइपरटेंशन. जब आप फिनाइलेफ्रीन शुरू करेंगे आपके पेशेंट्स की हर 5 मिनट्स 15 मिनट्स से 30 मिनट्स पे आपको पता होना चाहिए कि आपके पेशेंट्स की प्रेशर्स की रीडिंग्स क्या है, उसकी ईसीजी क्या है, पहली बात. दूसरी बात यह है कि फिनाइलेफ्रीन जब भी आप देंगे पेशेंट को तो आपको पता होना चाहिए कि आपने कितने डोज तक देनी है. ठीक है, यू विल नॉट एक्सीड 1 मिलीग्राम इन 1 आवर. यू विल नॉट एक्सीड 1 मिलीग्राम इन 1 आवर. ठीक है, इसीलिए आप माइक्रोग्राम्स में देते हैं. अब सपोज करें कि आई एम स्टैंडिंग एट द बेड साइड और मेरे पास पेशेंट है इस्केमिक प्रायपिज्म का. एस्पिरेशन मैंने कर ली, उससे कोई फायदा नहीं हुआ. मैंने फिनाइलेफ्रीन शुरू किया पेशेंट को. ठीक है, मैंने 250 माइक्रोग्राम से शुरू किया, दैट इज 0.5 mg. ठीक है, जब मैंने 0.25 mg, तो जब मैंने उसको 250 माइक्रोग्राम से शुरू किया तो हर 5 मिनट्स में मुझे उसको देना है. तो कितने में 1 mg हो जाएगा? 20 मिनट्स. ठीक है, सवाल ये कि व्हाट यू आर गोइंग टू डू आफ्टर 20 मिनट्स. मैंने तो कहा है कि 1 आवर में 1 mg एक्सेड नहीं करना. ठीक है, तो देन यू हैव टू वेट. कुछ भी हो जाए आप 1 mg से एक्सीड नहीं करेंगे. ठीक है, दैट इज द रूल. ठीक है, उसके बाद उसके साइड इफेक्ट्स जो आना शुरू होंगे तो फिर शायद पेशेंट, क्योंकि पेशेंट वैसे ही लोकल में होगा, लोकल एनेस्थीसिया में होता है. ठीक है, तो उन साइड इफेक्ट्स को प्रिवेंट करने के लिए 1 mg से एक्सीड नहीं करेंगे आप. ठीक है, और अगर आप 200 माइक्रोग्राम से देते हैं तो आप 25 मिनट्स में पूरा कर लेंगे, और आप अगर 100 से देते हैं 5 मिनट्स में तो फिर आप 1 आवर तक ले जा सकते हैं उसको. ठीक है, तो जब भी अगर फिनाइलेफ्रीन खत्म हो जाए 25 मिनट्स हो 30 मिनट्स हो, उसके बाद आपने वेट करना है, आपने ऑब्जर्व करना है. अगर 1 आवर में नहीं होती है अचीव दैट डिस्टेंस तो देन यू हैव टू प्रोसीड टू द नेक्स्ट स्टेप. आपने उसको रिपीट नहीं करना है. ठीक है, और कुछ एस्पिरेशन पे. एस्पिरेशन जब आप करते हैं ना तो व्हाट आर द सक्सेस रेट ऑफ एस्पिरेशन, ये बहुत इंपॉर्टेंट है. अगर सपोज करें कि मेरे पास इतना पोटेंट एजेंट है फिनाइलेफ्रीन, तो व्हाई आई एम डूइंग एस्पिरेशन? किसी को पता है इस बात का जवाब? एस्पिरेशन का जो सक्सेस रेट है ना वो इसमें 36% लिखा हुआ है, बट इट्स 18 to 36%. इट्स इन अ रेंज. ठीक है, अगर मैं डायरेक्टली किसी को फिनाइलेफ्रीन स्टार्ट करूं तो मेरा सक्सेस रेट जो होगा ना वो होगा ऑलमोस्ट 50 to 56%. बट रिमेंबर, अगर आप किसी को एस्पिरेशन करें और उसके बाद आप फिनाइलेफ्रीन पे स्विच करें तो उसका जो सक्सेस रेट होगा वो इट विल रीच टू अप टू 80 to 90%. That is the reason कि phenylephrine is used as a second line treatment. ठीक है, क्योंकि उसका सक्सेस रेट बढ़ जाता है.
Okay, so in starting priapism, the goal of management is the prevention of future episodes. So we can, so for that we prescribe oral alpha adrenergic medications like atelephrine, 0.5 mg per kg at bedtime. And then there are also hormonal therapies that are given to like GnRH agonists and anti-androgens. But these are contraindicated in children who have not completed their growth and sexual maturation, and in those who are trying to conceive. And baclofen, oral baclofen is also given at 40 mg at bedtime, and it inhibits penile erection and ejaculation through GABA receptor activity. So it is given at night time, because in children mostly the episodes of priapism occur at night time or in cold. So it is given oral 40 mg at bedtime.
इसमें एक बात ये है कि एटिलफ्रीन तो पता है आपको कि सिम्पथोमाइमेटिक एजेंट है, तो कॉन्स्ट्रिक्शन करेगा और प्रिवेंट करेगा. ये GnRH एगोनिस्ट और एंटी एंड्रोजेंस किस तरह करेंगे? Anyone knows the mechanism? Basically, it's about testosterone. टेस्टोस्टेरोन जो होता है ना, वो अप रेगुलेट करता है फॉस्फोडाइस्ट्रेज की एक्टिविटी, और फॉस्फोडाइस्ट्रेज जो होता है ना, वो नाइट्रिक ऑक्साइड को इनहिबिट करता है. ठीक है, तो फॉस्फोडाइस्ट्रेज को अगर रोकना है आपने, तो आपने इनडायरेक्टली उन्होंने कहा है कि आप GnRH एगोनिस्ट दे या एंटी एंड्रोजेंस दे, तो यू विल स्टॉप टेस्टोस्टेरोन, और टेस्टोस्टेरोन अप रेगुलेट नहीं करेगा फॉस्फोडाइस्ट्रेज 5, और अल्टीमेटली आपके पास नाइट्रस ऑक्साइड ज्यादा अवेलेबल होगा, जो कि पहले आप पैथोफिजियोलॉजी में पढ़ चुके हैं कि नाइट्रस ऑक्साइड ही स्कैवेंज होता है. ठीक है, इसके बाद जो दूसरा है बैक्लोफेन का जो ज्यादा इफेक्ट है वो न्यूरोलॉजिकल है, कि वो गाबा रिसेप्टर्स को इनहिबिट करती हैं और वो पैरासिम्पैथेटिक की ड्राइव को कम करती है. ठीक है, इसी तरह ये प्रायपिज्म को कम करती है.
Then PDE5 phosphodiesterase enzyme inhibitor is also used as selective vasodilation of the corporal blood vessels, and it prevents the sickling of red blood cells. So in this, there are also sildenafil and tadalafil are also used, and they are given 3 times weekly. And intracavernosal self-injection of phenylephrine can also be used in stuttering priapism, and in patients who either fail or reject a systemic treatment of stuttering priapism. And oral terbutaline, that is also a beta-2 agonist with the minor beta-1 effects, is also used. And a dose of 5 mg has been suggested to treat the prolonged rejections lasting more than 2.5 hours.
टर्बिटुलिन का जो मैकेनिज्म जिसमें लिखा है ना कि इट्स नॉट येट फुली अंडरस्टूड, बट इसमें जो टर्बिटुलिन के लिए जो कहा जाता है ना कि इट्स अ बीटा-2 एगोनिस्ट, तो बीटा-2 एगोनिस्ट को अगर आप देखें तो इट इंक्रीजेस द सिंपैथेटिक एक्टिविटी. तो जब किसी पेशेंट की सिंपैथेटिक एक्टिविटी आप इंक्रीज करेंगे ना, तो उसकी पैरासिम्पैथेटिक खुद ब खुद डाउन होगी, और सिंपैथेटिक एक्टिविटी लीड्स टू डेथोमेसेंस. इसीलिए ये बाजों का अक्यूट फेज में भी आप यूज कर सकते हैं, बट उसका डायरेक्टली अक्यूट फेज में रोल नहीं होगा. अक्यूट फेज में रोल सिर्फ एस्पिरेशन का, सिल्डेनाफिल का, फेनाइलेफ्रीन का, जो कि इंट्राकैवर्नोजल एजेंट है. हाँ, उसके बाद अगर आप देना चाहें तो देन दिस ड्रग वुड हैव सम इफेक्ट, वरना नहीं होगा. स्टटरिंग प्रायपिज्म में इसका रोल है एज अ प्रोफाइलेक्टिक डोज ड्रग.
So now the surgical management of ischemic priapism. So as we discussed, the first is aspiration, but if it fails, then we have other options. And the principle of most of the priapism surgeries is to create a fistula between the engorged corpus cavernosum and glans. And as the glans is not made of the glans is made of corpora spongosa, so basically we have to create a connection between the corpora cavernosa and the spongosum to cause the blood to flow through the cavernosa into the spongosum and release the erection, release the tumescence of the cavernosa. So there are various options, and there are distal shunts also, and then there are proximal shunts, and then there are venous shunts. So here are some options of the percutaneous distal shunts, in which the shunt procedures are subdivided on the basis of anatomy. There are distal cavernoglandular shunts, and they are the first choice of shunting procedures. And then the shunt is to be considered for ischemic priapism also, which ischemic priapism events lasting 72 hours. So if, as we discussed, that if we have tried aspiration, we have tried phenylephrine injection, and it does not go away, then the option is the surgical of creating a shunt. And the objective, as I discussed, that it's reoxygenation of cavernous smooth muscle. So we have to create a channel through the which can connect the corpora cavernosa to the spongosum, and create a channel through which the blood can flow through the cavernosa into the venous or into the corpora spongosa. So there are different kinds of shunt. So first we'll discuss the percutaneous shunt, which are distal percutaneous shunts. The first of all is the winter shunt, in which there is a distal cavernoglandular shunt procedure, and is created by transglandular placement of a large bore needle or angiocatheter into distal glands and corpora cavernosa. A core of tunica albuginea separating the glands and the corpora cavernosa is removed with the needle, thus creating a fistula. So as I told you that it's the glans is made up of spongiosum, and behind that there are the cavernosal bodies. So if we inject a needle through the glans into the corpora cavernosa, it basically creates a channel through which the blood from the cavernosa can come into the spongiosum and release the tumescence. The other kind of distal shunt is ab hoc shunt, in which basically we use 11 blade on the despite instead of the needle. So we use a blade and we give an incision into the glans and the corpora cavernosa, and the mechanism is same, and we have to just create a channel. So needle is a small thing, so we can also use a blade, 11 blade, which can have a more bigger channel than a needle injection. So the oxygenated blood is milked out of the open incision, and then the bright red blood. When the bright red blood is seen, the skin is closed, leaving the deeper incision open for the surgical fistula. So will only close the skin, so the connection will still be there between the spongiosum and the cavernosum. Then there is a T shunt. It's also the same. The mechanism is same. We have to create a channel. So it is a bigger incision. It is a T-type incision, as you can see in the picture. The incision is given first vertically and then horizontally, and the blade is inserted into each corpora cavernosa. We can use it. We have to give it on the both sides, because there are two corpora cavernosal bodies. So on the both sides, the blade is inserted into each corpora cavernosa from the glans and turned 90 degrees away from the urethra, and then pulled out to create a T-shaped shunt. The deoxygenated blood is milked out of the open incision, and once the bright red blood is seen, we can close the skin. So these were the percutaneous, in which we have to only give an incision. But if it does not go away through that, then there are other shunts. That is, Al-Ghurab shunt is one of its kind, in which there is indicated the percutaneous shunting fails to reestablish blood flow. It requires excision of the circular cone segment of the distal tunica albuginum. As you can see in the picture, we remove the whole part from the skin and the corpora cavernosa, so that the blood can go through the from the cavernosa into the spongiosum. A transverse incision is made on the dorsal aspect of the glans, approximately 1 centimeter, and then when detumescence occurs, the skin is closed. So basically the mechanism is same, but in this we have to give a bigger incision, and we have to remove a chunk of skin and corpora cavernosa, so that it can so that the communication occurs between the cavernosa and spongiosa. And then when we have aspirated all the dark blood, so once the red blood is there, we remove we can close the skin defect. Then there is this is another type of distal shunt, open corporal snake burnet, and in this we see that there is a large Hagar dilator which is used, and it is advanced through the tunica windows proximally, and to release the blood of and thrombus. Basically, we give the incision. When we see there is a corpora cavernosa, we insert a dilator, and we create a channel. And then when the blood is when there is a fresh blood, we close the skin defect. Then if it fails, then the other option is also proximal shunts and venous bypasses. In proximal shunts, what we do is basically we can create a channel between the corpora cavernosa and spongiosa more proximally, but these are avoided actually because there is a higher risk of urethral injury in these shunts. So these are two venous bypasses that are also used. The first one is a Gehek cavernoso-saphenous shunt, in which the saphenous vein is mobilized and is by dividing and ligating its tributaries, and then it is anastomosed to corpora cavernosa. So we basically create the venous shunt, and we connect the venous supply to the corpora cavernosa, so that the blood gets drained through the saphenous vein. Then there is a Berry cavernosa dorsal vein shunt, and it is also the deep dorsal vein of the penis that is anastomosed with the corpora cavernosa, and the shunt is created between the deep dorsal vein and the corpora cavernosa. So the key factors for successful surgical reversal is evacuation of the thrombus, reestablishing cavernous inflow, and the patency of the shunt. So as we see that if there is a obstruction in venous outflow, then we have to evacuate all the dark blood and the thrombus into the of the corpora cavernosa and reestablish the cavernous inflow. And the patencies of the shunt is also monitored and kept patent. Assessing the shunt patency includes visualization of the bright red blood in corporal aspirate, corporal blood gas analysis, color Doppler ultrasonography, and measurement of intracavernous pressure and penile compression maneuver. So these things can be used to monitor if a shunt is working or not. What complications can occur? Penile edema can occur, hematoma, infection, and urethral fistula if our shunt is closer to urethra, or it is causing the urethral damage. So a urethral fistula can also be created. Conversion to high flow priapism. So what happens is basically we saw that if we have damaged any cavernosal artery while doing the shunt procedure, so it will again form a fistula between the cavernosa and artery. So it will cause a high flow priapism. So as I told you that it's also one of the causes of high flow or a non-ischemic priapism, that we did a shunt procedure in that we damaged the cavernosal artery, and then the fistula, there is a fistula formation between the corpora cavernosa and artery. So there's a high flow, the low flow priapism got converted into a high flow priapism. And penile necrosis can occur again if the blood supply gets compromised. It will cause penile necrosis and pulmonary embolism, which is a complication of the thrombus that gets dislodged and get into the blood circulation and cause pulmonary embolism. Prevention of shunt obstruction and failure. So we have to avoid the compressive penile dressing, periodic squeeze and release of distal penis to milk the shunt, maintaining patency, and anticoagulation therapy. So if we have to keep the shunt patent, we can use aspirin or heparin post-operatively. So the shunt is a patent. And finally, if we have been
I would like to say something in blind prosthesis. अगर हमारे पास एक patient present होता है within 24 hours, then there are very good chances कि हम उसका जो fibrosis है, corporal fibrosis, हम उसको prevent कर देंगे अगर हमने उसका treatment सही किया तो. But पुरानी older जो literature था उसमें ये था कि within 72 hours आप इन सबको करके आप prevent कर सकते हैं. But now ये कहा जाता है कि अगर patient presented to your emergency department after 48 hours of priapism, then there are very much chances कि fibrosis is inevitable. ठीक है. So in that case, you have to go for directly penile prosthesis. Early penile prosthesis के बहुत ज़्यादा फायदे हैं. सबसे जो दो फायदे जो मेन जो सबसे बड़े फायदे हैं, वो सबसे पहला फायदा ये है कि फाइब्रोसिस की वजह से जो पेनाइल शॉर्टनिंग हो जाती है वो नहीं होती. ठीक है, तो आपको पेनाइल लेंथ अच्छी मिल जाती है. दूसरी बात है कि ड्यू टू फाइब्रोसिस द इंसर्शन ऑफ पेनाइल इम्प्लांट बहुत मुश्किल होता है, वो भी नहीं मिलता आपको. तो कॉम्प्लिकेशन ऑफ प्रोस्थेसिस आगे जाके बहुत कम हो जाती है. तो इसीलिए कहते हैं कि इफ द पेशेंट हैज प्रेजेंटेड आफ्टर 48 आवर्स, तो देन यू हैव टू काउंसिल द पेशेंट के पेशेंट को इरेक्टाइल डिसफंक्शन होगा. ठीक है, और अल्टीमेटली उसको पेनाइल प्रोस्थेसिस में जाना पड़ेगा. द टाइम ड्यूरेशन इज रिक्वायर्ड इन काउंसलिंग ऑफ द पेशेंट. ठीक है.
Yeah, so all these points have been discussed by Dr. Mubin. Moving forward, what can be the complications of penile prosthesis, as it is an implant, so infection can always be there. Urethral injury can happen, and device migration and device erosion can also occur. Lastly, the management of non-ischemic priapism. As we discussed, it's not an emergency because the arterial flow is there, oxygenated blood is there, so there is a very low chances of erectile dysfunction or fibrosis being happening. So it can also resolve spontaneously, or it can also respond to conservative therapy. Partial erection resolved in 4 days and normal erection in 2 weeks later. Cavernous aspiration has only diagnostic role in high flow priapism, and because if the blood is dark, if the blood is bright red and it's not ischemic, it's not acidotic, so it will not cause more damage to the cavernosa. And for patients demanding immediate relief, selective arterial embolization is offered. If it is not going, and it's also, if it is persistent, and however it is not causing any pain, but it is it is there, so we can help it by giving selective arterial embolization. And selective pudendal artery embolization has the highest success rate, 89 to 100%. In cases of long-standing priapism in which a pseudocapsule developed around the fistula, surgical ligation is successful. And color Doppler ultrasound guidance is recommended during exploration to locate the fistula. So that's it. This is the summary of the whole presentation. So basic is to the basic thing is to diagnose and to evaluate whether it is ischemic or non-ischemic. That's the most important step in evaluating or managing priapism, because if we can know if it is ischemic, so we have to intervene swiftly. So then the steps is aspiration, intracavernosal sympathetic drug, and then the shunting procedures that we discussed. And if it is non-ischemic, we can go towards the conservative therapy or angioembolization later on. Thank you so much. This was my presentation.